Good morning, everybody. My name is Stuart Schlossman, and we're here this morning with Patricia Pagnotta. And Patricia's going to tell us a little bit about herself.
Good morning. Thank you, Stuart. I am a nurse practitioner. I'm certified. I also have a master's degree in nursing. I am a certified nurse in multiple sclerosis. I also have a certification in neuroscience nursing. I work at Neurology Associates and the MS Center of Greater Orlando, which is in Maitland, Florida, a little north of Orlando. I've been doing that for over 10 years. I work with a physician, Dr. Honeycutt, but there are 4 physicians in our practice.
Great. So MS Views and News asked you here today because we'd like to ask you a few questions about MS relapse and about the different infusion therapies. So to begin with, I'd like to ask you a question about MS relapse. Can you tell us what this is?
Very good questions, because even persons who've had multiple sclerosis for many years get confused about what a relapse is. A relapse can be a new symptom, and persons think that is a little easier to detect, but it can also be an old symptom that comes back and is much different, much more severe than it has been. The key to identifying a relapse is it needs to last longer than 24 hours, and most relapses last much longer than 24 hours. So it has to be consistent, longer than 24 hours. The other thing is we want to make sure that it's coming from the central nervous system and is not associated with anything else. So we want to make sure that persons don't have urinary tract infections, any other type of infection or medical illness, haven't started new medications that might be causing them to have symptoms. There's not anything in their life that they've done different. Like in my area, persons may go to Disney, have family members visit, and they go to Disney and spend all day out in the hot sun, and then the next day they're extremely fatigued, much more fatigued than they've been before. That's what we would call a pseudo-relapse or an UTOS phenomena, persons that get very stressed in the checkout line. They may find if they've ever had an optic neuritis before and they're very stressed in the checkout line and they can't get to their credit card because they've got some sensory problems, that increases their stress, and then they may have difficulty seeing. And that may last them for a while, and they may not have had that for a long time, and they think, oh, I must be having a relapse. But when they cool down and they're not as stressed, that seeing problem goes away. So it didn't last for 24 hours, so it's not a relapse. Infections, though, oftentimes can make symptoms last for more than 24 hours, so that's the key there. Again, we're looking for things that are only coming from the central nervous system.
So how would a patient actually recognize that they might be having a relapse other than a symptom lasting for 24 hours? How would they know that it is a symptom, but maybe it's a new symptom? I mean, what would enable them to say, hey, I need to go see my clinician?
Good question. I ask persons to know themselves. The key is you know your body, you know how you respond, and if something new or different happens to you, it's not really your job to figure out what that is. It's your job to notify your healthcare provider. I don't want persons to worry about they have to be their healthcare provider. No, they have to be an advocate for themselves, and they have to know their body and know when something is different. And whether it's a relapse or something else, if something new or different is occurring, they call us, we figure that out. So it's really, do they know themselves? What happens on a daily basis? Keep track of that. And if something new or different happens, call your healthcare provider. Leave it in the hands of the person who's their advocate for their medical care to decide whether or not it's a relapse.
So speaking about the patient then seeing their healthcare provider, is the healthcare provider going to require that they have an MRI to determine if they are having a relapse?
That's a very good question. So I tell persons that yes, an MRI does not necessarily always show a relapse. And so then when I'm talking to persons, they say, well, I remember you said that in order to have a relapse, I don't have to necessarily see it on an MRI. I might have an MRI that shows no new lesion, but yet you're telling me I'm having a relapse. So why do I now have to spend the money if you think my symptoms are new, if you can assess it? Why do I have to spend the money to go have an MRI done? Well, an MRI helps us make sure that there's nothing else going on. So now in this day and age with the different medications we have and the risk profiles with some of those medications, it's important to be clear that what's coming from the central nervous system is MS. and not something else. So an MRI that doesn't necessarily show a new lesion still will show that there's no infection, there's no other pathology like a stroke coming up, and we know that, yes, it's MS, and then we would do the appropriate treatment for MS. If it wasn't MS, we'd have to change the treatment strategy and go a whole nother route.
Okay, so here I am. I'm the MS patient. Now, I just had this MRI. I had other things looked at me. I definitely feel lousy, and you're telling me that I'm having a relapse. What do we do now? How am I going to combat this relapse?
Another good question. So there are treatments that we can give to help acute worsening neurologic symptoms, relapse symptoms. Commonly, the most common treatment right now is IV methylprednisolone, which is IVMP. And that's an IV medication that's given to persons over 3 to 5 days. So they get a daily treatment over 3 to 5 days, depending upon how severe their relapse is and their medical history. If persons have not responded to IVMP in the past or have had negative response side effects from IVMP, there's another drug called Athgar, ACTH, which is a hormone that causes your body to make its own natural steroid. That also can be used to treat a relapse. So if persons didn't respond or have had a poor response side effect from IVMP, they can get Athgar. Athgar is a drug that is self-administered, so you don't have to have someone come in or you don't have to go somewhere else to get an IV. You can self-administer that drug, either subcutaneous or IM, in your own home. And based off of the clinical trials with Athgar, we can give that over a week, 2 weeks, and even up to 4 weeks, depending upon the severity of an individual's relapse. Then there are also other treatments. You can give person plasmapheresis. You can give them IVIG. Plasmapheresis would, in most cases, require a hospitalization. Oftentimes with IVIG, it does require a hospitalization, or if you have a good home health infusion network, then some persons can get that in their home. And most of these two treatments are over 5 days.
How come we don't hear more about Athgar over Solumedrol?
Well, Athgar is a little bit more expensive than Solumedrol, and so it's not a first-line treatment just because of the expense of that. So that's why you don't hear more about it, I think, because most persons don't want to go that expensive route unless there are persons who truly need that. Persons who, A, can't get IV access, B, they've had side effects from the Solumedrol or prednisones, or C, they haven't worked for them in the past. So the key is that persons need to know, again, need to know their bodies, need to share with their healthcare providers, well, the last time I had a relapse, I got Solumedrol, IVMP, and it didn't do anything for me. I didn't get better at all. It didn't stop my symptoms. And so they share that with their healthcare provider, and that gives the healthcare provider grounds for trying something different, because insurance companies are all about conserving money.
What happens if a patient says, okay, I'm having a relapse, but I don't want to go on to any of these medications?
Well, that's entirely up to the individual. I would try to encourage the person to think about, why would I treat a relapse? I treat a relapse to help speed the progression and help bring down the inflammation that's occurring, and so hopefully that relapse doesn't progress to become worse than it is at the time I see the person, because we usually see persons very early in their relapse. We say that relapse occur 30 days in between, because what we know can happen with a relapse is a person may present, let's say, with right arm weakness, numbness. That can progress to be the whole right side of the body during those 30 days. So a person initially who tells me, well, I don't want to be treated, I try to explain to them, well, I'm trying to bring down the inflammation so that more involvement of your central nervous system doesn't occur, but B, it helps speed the recovery. There's no guarantee that when persons have relapses that they will get back to their baseline, but we're trying to help speed that process. And most importantly, a lot of times relapses are painful for individuals. And treating a relapse will remove some of that pain. So even if it doesn't help a person improve dramatically quickly, it removes some of the discomfort that they're having. Now, I mentioned drugs for treating relapses, and so it's important to know that depending upon the relapse, drugs are the first line to start, but persons need to then consider physical therapy, occupational therapy, speech therapy. Again, depending upon what their relapse looks like, they need other therapies. So yes, we pull down the inflammation, but the brain is a plastic organism. It can learn to recover, learn to do things a different way. And so it's key that while a person is having a relapse, we're helping the brain learn then what to do, not 3 months later when they're left with residual weakness and new deficit or something that we're, oh, now let's do physical therapy. No, that was better to start when the person was having problems, so the brain starts learning then, not when it's already shut down and has left a mark. So you want to retreat then. So there's drugs that need to be potentially considered, and I advocate for drugs. But outside of that, persons should be open to physical, occupational, and speech therapy depending upon what their symptoms are.
Well, thank you. Thank you for all your answers today. They were all excellent, and I am sure that there are going to be many people out there that are going to learn greatly from this interview. Thank you very much.
Great, thank you.